Good afternoon, everyone. Thank you for staying with us for this final presentation of the day. My name is Rachel Sudarth, and I'm a professor here at the University of Richmond School of Law. Today, it's my pleasure to introduce Madison Harrell, a third-year student here at the University of Richmond. Madison serves as articles editor on the Law Review, and she has been a standout student her entire time here at the University of Richmond. During her second year, I had the pleasure of having Madison participate in my Health Reform in America seminar course. And during that class, she focused her independent research on Medicaid expansion. I'm thrilled that Madison's paper, Expanding Medicaid in the Postpartum Period, was selected for publication by the Law Review, and that she's able to share her reform proposal with you today. At the end of Madison's presentation, we'll have a few minutes for questions. So if you have a question, please type it in the chat and I will ensure that Madison has an opportunity to answer it at the close of her remarks. Madison, we look forward to hearing from you.
Okay, thank you, Professor Sudarth. Also, thank you to the University of Richmond Law Review for having me today and for selecting my comment for publication. It's a huge honor and I'm really excited to talk to everyone today. So let me just share my screen. So like Professor Sudarth said, my paper focuses on how the federal government can mandate an expansion of Medicaid benefits during and after pregnancy in order to help combat the maternal health crisis that the United States is currently facing. So I wanted to start with just a brief overview of the history of Medicaid and especially how it relates to pregnancy and postpartum coverage. So Medicaid was signed into law in 1965 as part of the Social Security Act. And at that time, it was meant to provide some coverage to a small number of certain low income and disabled individuals and families. It was not really meant to be a comprehensive social welfare program for all low-income Americans, and eligibility was originally tied to the receipt of cash payments under certain federal assistance programs that targeted these groups that were considered what I would consider not the best term, but the deserving poor of the aged, blind, disabled, and some families with dependent children. That framework mostly remained until the mid-1980s, when concerns about infant mortality and children's health prompted Congress to start expanding the program a bit. Specifically, these programs through the mid-80s up until 1990 focused on pregnant women and into the immediate postpartum period, and that ultimately culminated in what is still law today, which is that states are required to cover pregnant women with incomes up to 138% of the federal poverty level until 60 days postpartum, regardless of any changes in income or assets. And as you can see today, this Medicaid program and this framework has proved vitally important to the health of pregnant Americans. Over 40% of births are covered by Medicaid today, so there is a big incentive to make sure that more people can be covered if it can help maternal health. So that was that last reform in 1990 was sort of the last big change to Medicaid until 2010 with the Affordable Care Act. And the Affordable Care Act was initially envisioned as a complete overhaul of the United States healthcare system. It was meant to bring about universal healthcare for the first time in the United States. And one of the biggest provisions was Medicaid expansion. It was an expansion of eligibility to all Americans up to 138% of the federal poverty level at an initial 100% federal matching rate that then declined a little bit over the years, but remained high. Further, the Department of Health and Human Services was empowered to withhold all Medicaid funding from states that chose not to implement this expansion. So it wasn't technically mandated in that it was written into the law, but if you did not do it, they would withhold all of your Medicaid funding that you were already entitled to. However, as I think we all know, the ACA was immediately challenged in court, and the Supreme Court ultimately ruled that the government could not hinge all Medicaid funding on expansion the way that they tried to do. Instead, that expansion had to be optional, which is the framework that we exist under now. And currently, the majority of states have expanded Medicaid under this scheme, but 12 states have failed to implement any sort of expansion under the ACA. Because of the way the ACA was drafted, the expectation was that every state would expand Medicaid. So the law as it stands right now means that individuals in states that did not expand are often left unprotected. In addition to the Medicaid expansion, another big provision of the ACA was the healthcare marketplace, where individuals who did not have either a Medicaid avenue or something like an employment avenue to health insurance could buy individual plans on this marketplace with the help of tax credits. But these tax credits started being given out to people with incomes at 100% of the federal poverty level and then went up to 400%. So that meant that in non-expansion states, people that were above the state threshold for adult individuals were not eligible for Medicaid. But if they were below 100% of the federal poverty level, they also were not eligible for the tax credits and could not afford to buy a plan somewhere else and didn't have any sort of meaningful avenue to coverage. As this relates to pregnancy, this means that while Medicaid must cover the pregnancy and up to 60 days postpartum for all people with up to 138% of the federal poverty level, once those benefits stop at 60 days, the postpartum parent risks falling into this gap of coverage that's literally called the coverage gap. There's a very large percentage of pregnant or postpartum mothers who fall into this coverage gap and lose coverage. And it also creates something called churning, which is exactly what it sounds like, where you churn between periods of insurance and uninsurance. This makes the ability to access care very uneven and can disrupt continuity of care, which then can disrupt health outcomes. So my proposal is essentially to bridge this coverage gap through a federal mandate and expanding the eligibility criteria for Medicaid. So specifically, my proposal is a federal mandate of 1 year of postpartum Medicaid coverage for all individuals up to 200% of the federal poverty level. And then this coverage lasts regardless of any changes in income. That won't affect anything. Once you're in the system, you stay on the system for the full year, regardless of if your income changes. Additionally, services provided during this extended coverage period will receive an enhanced 100% federal matching rate, and the coverage will be the full Medicaid benefits package. It won't be some sort of reduced pregnancy only package, because that's really just administratively not great. And it's also not great from a health perspective, because postpartum care really is comprehensive care in that, that first year of postpartum period. And then finally, states that already have income thresholds for pregnancy Medicaid above 200% can keep that threshold level. And any state can also have the option of expanding the threshold up to 400% of the federal poverty level if they so choose. And this will receive the same 100% matching. So the reason that this proposal is really needed is because the landscape of maternal health in the United States is not great. Worldwide maternal mortality rates have been declining. As of 2017, the US was one of only 2 countries to report a significant increase in the maternal mortality rates since the year 2000. I believe in recent years it has leveled off and even declined a little bit, but it was rising for 2 decades, and that was a big problem. Data from 2018 also shows that that there's a maternal mortality ratio of 17.4 deaths per 100,000 live births in the United States. And this is by far the worst among every industrialized country. In fact, it is double the next worst country, which is France, which has a ratio of a little over 8 deaths per 100,000 live births. So it's definitely a very big discrepancy between us and other developed nations that is frankly unacceptable with our resources and the amount of money that we spend on healthcare in this country. Further, over half of pregnancy-related deaths occur during the postpartum period. You can see here what the breakdown of when deaths occur is. but 12% do occur between 6 weeks and 1 year postpartum, which is really the time that this proposal focuses on. That's 42 days. Benefits right now end at 60 days, but the postpartum period lasts for a full year following birth. Additionally, research has shown that over half, or more than half of pregnancy-related deaths are considered preventable. We just are not doing enough currently to prevent them. Causes of death also, they vary quite widely throughout pregnancy and afterwards, but in the late postpartum period that we're focusing on, 6 weeks to 1 year, the most common causes of death are heart conditions and mental health conditions, which are both, I think, obviously conditions that if you can get access to care, get a diagnosis and get treatment, you have a more meaningful opportunity to treat and then prevent deaths occurring because of them. Additionally, the risk of death is not stagnant across the United States. There is a lot of variation between the states. A lot of states are actually missing data on this, but of the states that do report, 4 reported ratios of more than 30 deaths per 100,000 live births, and only 5 reported ratios lower than 15 deaths per 100,000 live births. So I know that's a lot of numbers, but as you can see, the risk of death in the United States is quite large when you compare it to other industrialized nations. Even in the states that are considered doing well relative to the rest of the United States, they're still not doing as well as other countries are. And so that's the real problem. There is also a discrepancy for race. Black women are 3 times as likely to die as white women. And unfortunately, the scope of my paper does not allow a comprehensive discussion of why that is, and it is not just an access issue. This paper does focus on access and promoting access to care, but there's a lot of other issues at play here, some of which the other presenters today have actually touched on a little bit, such as the social determinants of health, in addition to things like bias within care by providers themselves. So those are things that need a more holistic approach to actually combating the racial disparities in maternal health outcomes. But this proposal is sort of a jumping off point to really combating the crisis as a whole. Additionally, deaths is obviously not the only risk of pregnancy. There's also maternal morbidity, which is injury as relates to pregnancy. And there is not as much data on that, but it is also not great in America when compared to other industrialized countries. And access to care can also help combat some of the issues you see there. So this proposal, I think, is really necessary for a number of reasons that are kind of outlined here. The first one is that access to continuous care really does improve maternal health outcomes. That's what the research is showing. And it's also showing that losing care threatens those health outcomes. So research has shown that coverage before, during, and after pregnancy lead to better health outcomes for parents and for babies, and that continuity of care is particularly important. And continuity of care just means keeping the same care plan without going through that churning of losing health insurance and having to gain it somewhere else, or not gaining it at all due to the barriers that we see facing mothers in this country. Poor continuity of care has been found to be a major factor in a lot of preventable pregnancy-related deaths, especially during the postpartum period. So it is something that is very important to this proposal and why it is needed. Because ultimately the goal of this proposal is to prevent the churning problem by ensuring that any postpartum person eligible for Medicaid benefits will not have to worry about their coverage ending in that first year after giving birth, because that first year is so vital to health outcomes and to preventing death. As a bonus, ensuring continuity of care has been shown to lead to more positive outcomes in subsequent pregnancies. So that's also a really great reason to adopt this plan. Further, we've also seen after the ACA that expansion states that have expanded Medicaid under the ACA, are having better outcomes than states that did not expand their Medicaid programs. So postpartum uninsurance does persist still in Medicaid expansion rates, but at a lower rate. And research has shown that Medicaid expansion is directly tied to higher rates of postpartum coverage. So in both expansion and non-expansion states, there are very low rates of uninsurance at the time of delivery. It's about 2% in expansion states and a little over 4% in non-expansion states. However, once you get past that 60-day cutoff, expansion states show a much lower rate of uninsurance, and the uninsurance rate in expansion states really blows up. Postpartum individuals in non-expansion states are 3 times more likely to be uninsured 3 to 6 months after childbirth than individuals in expansion states. So you can see that there's a big discrepancy there, and that's something that we need to address and that I think this proposal will help with. Further, Medicaid expansion has been linked to a decrease in maternal mortality of 1.6 deaths per 100,000 live births, according to analysis of data from 1999 to 2016. So data starting before ACA and in the first few years of the program. In the grand scheme of the Medicaid system and in our country, the ACA is still kind of in its infancy. So a lot of the data coming out of it is preliminary, but it is very promising. And even before that, it was shown that health coverage is really vital to promoting maternal health and making sure that, that babies and parents are staying healthy and staying alive. So all of that, the expansion state, states having better outcomes really makes sense, considering that Medicaid expansion leads to more continuity of care. You have more people covered, and you have them covered regardless of being below that threshold of being able to afford tax coverage or tax credits, because they just stay on Medicaid under the ACA. So it makes sense that they can continue to see their same doctors, continue to get the same access to care that they had prior to pregnancy, and then as a result have better outcomes. Further, I think when you look at the issue with the backdrop of the ACA and what we know now, it's really clear to me, at least, that optional expansion is just not going to be enough to make sure that we have a comprehensive nationwide solution to this issue. And while there has been some progress both at the federal and state level, I don't think it's enough to overcome what would essentially become another patchwork band-aid to the problem, the same way the ACA was, in that some states choose not to do anything. Some states are really excited and really want to help, but it creates a lot of discrepancies in care that isn't really fair, considering, you know, we're all in one country and the federal government has the power to do something to even out those outcomes. So really, despite the generous incentives that were provided by the federal government, 12 states, as I said before, have resisted expanding Medicaid at all. And I think in most or all of those states, there's not really a path to expansion at this point. I'd love to be proven wrong, but at this point, I don't see one. I personally am from Kansas, and we are a non-expansion state. And I think that to promote expansion or to get expansion passed, there would either need to be a huge shift in the makeup of the legislature or of the ideologies of the people within the legislature. Even with our governor advocating for Medicaid expansion, I just don't think it's enough to actually get it passed. And I don't see Kansas doing like something like a ballot initiative, as some states have done, to pass Medicaid expansion. So I think that this proposal is really necessary, because we might have hit a bit of a wall when it comes to expansion under the ACA. Additionally, the federal government has shown some progress on this issue. They passed the American Rescue Plan, which was the comprehensive COVID relief package of President Biden's administration last year, and it has been signed into law, and that does provide a state option to expand postpartum benefits to a full year, but it only offers federal matching at the existing matching rate. So there's not really an incentive for states to adopt it. I think that it's only attractive to states that have already proven a willingness to expand Medicaid, but the states that have not shown that willingness, I don't think there's any incentive to actually sway them to choose that option. And those are the states that really need the plan the most. Additionally, this is a nationwide problem, so it requires a nationwide solution. At the time that I wrote this paper, there were some states that had already asked the federal government to approve their plans to extend postpartum benefits at a state level to a full year postpartum. I do believe some of those states have been approved, including Virginia last November. And I think that goes into effect this year. But again, it's only a few states at this point, a handful, and that's really not enough because it's only going to probably exacerbate the problem of the unequal outcomes among the states. And that's really a problem that we do not want to continue. And then next, I think this proposal can be very attractive to states due to the federal incentives, and I hope that it will reduce resistance to the plan. As I said, there's a 100% federal matching rate, so that means the states will not have to take on an extra burden of expansion. And it's also not a huge, broad expansion of the program that's encompassing a ton of new individuals who have never been covered by Medicaid before. A lot of the people who will get care under this program, under this proposal, will have already been eligible for Medicaid benefits. So this is really just expanding the amount of time that they can stay on it. And for some states, it will increase the amount of people on it, but not to an extent that it provides some of the concerns that I think some of these states who held out on expanding Medicaid under the ACA have about burdening their state Medicaid programs. So that's mostly just an overview of my proposal. I talk a lot more about these issues in depth in my paper and also touch on a few other issues, but I would be happy to take any questions people may have.
Great. So I'll leave the question queue up. We don't have any questions now, but luckily, as any professor would, I have a few questions for Madison while we wait for some others to come in. So your proposal specified that you would like mandatory coverage for postpartum beneficiaries up to 200% of the federal poverty line. Can you walk us through how you decided that 200% was the appropriate cutoff for that full year mandatory benefit?
Sure. So I chose 200%. I kind of modeled my proposal after a proposal by the Medicaid and CHIP Payment and Access Commission, who did a report to Congress advocating for a similar proposal, and they chose 200%. And a lot of that is because it's close to the national average. States are allowed to have a higher income threshold than the 138% mandated by federal law currently, and the national average is 195%. So this is similar. It really is, it covers the most vulnerable in our society. I don't know how many people are familiar with what the federal poverty level is. It's 100% is like $13,000, I think, in 2022. So it's very, very low. So this is really just aiming at getting the most vulnerable in our society the assistance they need.
Great. Along those same lines, the 200% of the federal poverty line is above the 138% threshold where individuals become eligible for ACA marketplace plans, where they can start to get the tax credits that would theoretically allow them to go to the ACA marketplace in their state and purchase private insurance on the marketplace. Can you walk us through why you feel that Medicaid for those between 138% of federal poverty line and 200% of the federal poverty line is for a lot of folks a better option than switching over to a marketplace plan?
Sure. I think the biggest reason for that is just promoting continuity of care. Like I said, if you have to switch over to the plan, you may not be able to keep the same doctor. You may, have to there may be some sort of gap in care. And I think that promoting continuity of care is really important in that first year. So that is why that staying on Medicaid is most important. There is also cost concerns. Just because you're above 138% of the federal poverty line doesn't mean that you may be able to afford care on the marketplace. It's a good program, but it's not it's not so great that everyone can afford a marketplace plan, especially if you're dealing with a new baby and all the costs that brings up. So I think that just keeping more people on Medicaid for that 1 year is really the best way to promote health and make sure they're not having to deal with the stress of switching plans or being able to afford a marketplace plan.
Great, thanks. I think we'll do one final question before we hand it back over to Ren for some closing remarks. You mentioned before that the mandatory expansion under the ACA for all Medicaid in all states was deemed unconstitutional. So could you tell us just very briefly why this type of mandatory benefit expansion would not fall victim to those same legal challenges? Why is this legal when a broader Medicaid expansion was deemed unconstitutional?
Right. So I really did craft this proposal and the whole paper around the NFIB v. Sebelius decision, where they decided the ACA's framework was unconstitutional. And I think in that opinion, they pretty explicitly authorized this. Chief Justice Roberts, when he wrote it, actually brought up the expansions of the 1980s as a permissible expansion of Medicaid. And they talked about how the ACA, that proposal was not really an expansion of eligibility, but instead requiring the states to create an entirely new Medicaid program, and that was not allowed. So I think that this is different because it really is an actual amendment of eligibility criteria for Americans, and it doesn't have that same creating of a new program. It's not, like I said before at the beginning, when Medicaid was never a comprehensive social welfare program for low-income Americans. And I think that the Supreme Court considered the ACA's idea as creating just that. And they did not think that the federal government had the ability to do that just by amending the Medicaid Act. So this is different because it is much more similar to those reforms of the 1980s that were held constitutional and have been in practice for decades now. I think also, just as a final point, that there's no coercion aspect, which was another issue that the Supreme Court had with the ACA, hinging all of those Medicaid funds on expansion of the program. This one is literally just going into the Social Security Act and changing 60 days to 1 year and changing 138 to 200%, and a few other changes, but it's just changing parts of the law that the federal government has complete control over and is not burdening the state, especially with the 100% federal matching rate and the lack of any ultimatum on current Medicaid funds.
Great. Well, not seeing any other questions. So thank you so much, Madison, for sharing your proposal with us. And with that, we will turn it back over to Ren Warden for some closing remarks.
Just one moment, please. Thank you, Professor Sudarth, and thank you so much to Madison also for sharing this with us today. This is such an important issue, and we on the Journal are so excited to have the privilege to publish your comment. We're so honored to have hosted all of this scholarship today. This has been a really good day for exploring the intersection between the legal world and public health, where this diverse array of issues can impact us on every level. Everything we've learned today can lead us, like I said before this morning, to developing a framework to form that more perfect union, one that promotes access to healthcare, improving health equity, and improving regulatory responses to public health issues. These presentations will be uploaded to our law school's YouTube channel, so feel free to refer back if you'd like. Most of the presenters will also be published in our journal in the upcoming symposium issue, which will be published next month, so keep an eye out for those articles as well. As I mentioned this morning, Mary Ruth Keyes will be sending out an email with CLE information. That's going to be early next week, so keep an eye out for that. And the last thing, just a couple of thank yous. Thank you again to all of the presenters at today's event. It's been a privilege to work with you all, and your engagement in your own presentations as well as with other presentations has been so exciting to hear. I want to give a huge shout out to Hannah Burton, my incredible associate symposium editor, as well as Kelly Bopp, the incoming symposium editor for volume 57. Thank you also to the rest of the staff on the Richmond Law Review. They've been such a team of cheerleaders over the past year. And thank you to Carl Ham, the law school's multimedia production and technology specialist. None of this could be done without you, ever. Finally, thank you all to the attendees for your attention and thoughtful interaction today. That's all for now. We hope you have a wonderful weekend. And the Law Review looks forward to seeing you next year for the same event. Thank you very much.